Hello and welcome to the topic Thalassemia in the Haematology module. By the end of this topic, you should be able to define thalassemia, explain the pathophysiology of thalassemia, outline the causes of thalassemia, outline the classification of thalassemia, describe the clinical manifestations, outline the investigations that can be done, discuss the principles of management, and discuss the complications as well as the prognosis of this condition. Let's get started. Let's begin by defining what thalassemia is. When we describe thalassemia, there are two main types. Firstly, beta thalassemia syndromes that are a group of hereditary disorders characterized by a genetic deficiency in the synthesis of beta globin chains. In the homozygous state, beta thalassemia is known as thalassemia major, and this causes severe transfusion-dependent anemia. While in the heterozygous state, known as thalassemia minor, the patient will have mild to moderate microcytic anemia. Alpha thalassemia syndromes, on the other hand, are a group of hereditary anemias of varying clinical severity, characterized by reduced or absent production of one or more of the globin chains, which human hemoglobin is composed of. Before we dive into the pathophysiology of thalassemia, let's understand more about hemoglobin. The normal adult hemoglobin that is produced after birth is hemoglobin A. This hemoglobin consists of heme molecules linked to two alpha globin and two beta globin chains, which is known as alpha 2 beta 2, with the alpha globin chain production dependent on 4 genes on chromosome 16 and the beta globin chain production arising from 2 genes on chromosome 11. Thalassemia is caused by the mutations or deletions of one or more of the genes that are responsible for the production of the alpha or beta globin chains. As a result, the rate of production of these chains will be affected, leading to decreased hemoglobin in the form of alpha thalassemia or beta thalassemia, and thus patients present with varying degrees of anemia. The degree of anemia is dependent on the degree of globin chain production impairment. Do take note that in carriers, thalassemia is usually asymptomatic. During fetal development, globin-producing genes will be switched on and off in order to produce different types of hemoglobins. In utero, the alpha globin gene is switched on for most of the time, producing fetal hemoglobin F or A2 gamma 2. However, once the baby is born within a few months, the fetal hemoglobin will turn into adult HbA or alpha 2 beta 2 chain with small amounts of HbA2 or alpha 2 gamma 2. The gamma globin production would be physiologically impaired at this point. Generally, we refer to severe mutations with complete absence of the beta globin production as beta 0 mutations, while less severe mutations are known as beta plus mutations. Please do bear in mind that the severity of the mutation may not always correlate with the clinical picture. Alpha thalassemia occurs when there is a deletion of one or both of the alpha globin genes on the same DNA strand. Interestingly, there have been more than 35 such deletions described up to date. Severe alpha thalassemia carriers are represented as alpha/negative to signify the absence of both alpha globin genes on the same strand. This is very commonly seen in carriers from Southeast Asia, Southern China, or the Middle East who are therefore at risk of having a stillbirth with HB hydrops fetalis. If an alpha-positive thalassemia carrier and an alpha thalassemia carrier have a child together, the child would have a risk of HBH disease represented by negative alpha. Both beta and alpha thalassemia can be classified into subgroups. Beta thalassemia can be classified into beta thalassemia minor, intermediate, and major. Beta thalassemia minor is a name given to those who are asymptomatic heterozygous carriers with normal to mild anemia and no organomegaly. Beta thalassemia intermediate or HBE-Thal presents with milder anemia that usually is seen after the age of 2. These patients will not require regular transfusion except in certain situations such as fulminant infections, oxidant drug use, and pregnancy. There may be presence of thalassemia facies as well as hepatosplenomegaly. Lastly, we have beta thalassemia major, which is also known as Cooley's anemia. And this occurs in homozygous patients where they will present with severe anemia seen at 4 to 6 months or before the age of 2. These patients will require regular blood transfusion as well as iron chelation therapy. They would have signs and symptoms of hepatosplenomegaly, jaundice, thalassemia phases, growth failure, and mental retardation. Just like beta thalassemia, alpha thalassemia may be divided into thalassemia minor, intermediate, and hemoglobin bad. Thalassemia minor or alpha thalassemia trait occurs when there is either alpha thalassemia 1 to 2 alpha globin genes deleted or alpha thalassemia 2 to 1 alpha globin genes deleted. Just like beta thalassemia, alpha thalassemia may be divided into thalassemia minor, intermediate, and hemoglobin bad. Thalassemia minor or alpha thalassemia trait occurs when there is either the alpha thalassemia globin genes deleted. Patients are usually asymptomatic, and this is usually an incidental finding. However, some may or may not have mild hypochromic microcytic anemia. Next, we have thalassemia intermedia, also known as HBH disease, and this is when there is deletion of 3 alpha globin genes or 1 functional alpha globin gene. Patients will have moderate chronic hemolytic anemia with a baseline HB about 7 to 10 grams per deciliter with a normal life expectancy. They would not usually require blood transfusion unless during fulminant infection, pregnancy, and the use of oxidant drugs. About 30% of the cases would have thalassemic phases, while approximately 70% would present with hepatosplenomegaly. Then we have hemoglobin bad hydrops fetalis, where there is deletion of all 4 alpha globin genes or 0 functional alpha globin gene. The fetus will be incompatible with life due to ineffective transport of oxygen, causing death in utero or in early infancy. And this is usually associated with complications such as eclampsia and obstructed labor. We will now discuss the clinical manifestations in both alpha and beta thalassemia in the form of symptoms and signs, starting with the symptoms. Just remember, in minor forms of both types of thalassemia, the patient may be asymptomatic. In a moderate or severe form of beta thalassemia, the patient will present with complaints of being paler than usual and having a yellow-tinged complexion, which is due to anemia and increased red blood cell destruction, resulting in hypersplenism respectively. Alpha thalassemia, more specifically those with HBH disease, will also come in with complaints of being more pale than usual. Moving on to the signs, patients with beta thalassemia trait generally have no unusual physical findings. In patients with beta thalassemia major, the physical findings are related to severe anemia, ineffective erythropoiesis, extramedullary hematopoiesis, and increased iron absorption. On general exam, there may be pallor due to anemia and jaundice from hyperbilirubinemia. They may also have deformed skull and other bones that may be deformed secondary to erythroid hyperplasia with intramedullary expansion and cortical bone thinning known as thalassemic phases. Skin ulceration may be present on the extremities, and in addition to that, the patient may show signs of failure to thrive or retarded growth as demonstrated by delayed puberty. On cardiac exam, there may be signs of heart failure and arrhythmias like atrial fibrillation, which may be due to severe anemia or iron overload. On abdominal exam, you will notice changes in the liver, spleen, and gallbladder, where there could be hepatomegaly, especially in those receiving blood transfusions, as well as chronic hepatitis due to iron overload. There may be also splenomegaly as part of the extramedullary hematopoiesis or as hypertrophic response to the extravascular hemolysis. As a result, this could lead to endocrine dysfunction, especially affecting the pancreas, testis, and the thyroid gland. Transfusion-associated viral hepatitis resulting in cirrhosis or portal hypertension may also occur. In patients with HBH disease, on the other hand, you will notice severe pallor, while those with hydrops fetalis usually die in utero, but those who survive to be born will have massive total body edema with high output congestive heart failure because of severe anemia. In addition to that, there will also be massive hepatomegaly due to heart failure and extramedullary hematopoiesis in these infants. The pathognomonic sign associated with thalassemia would be the thalassemic phases or facial appearance. This occurs due to ineffective erythropoiesis leading to bone changes where the bone becomes thinner and pathological fractures may occur. As a result, there will be changes in both facial and cranial bone causing the typical facial appearance seen in thalassemic patients. In patients with thalassemia major, characteristic craniofacial features include a rodent or squirrel-like face, larger cheekbones, protruding maxilla, and a depressed nasal bridge. The squirrel-like deformation is attributed to multidirectional growth, which covers the maxillary region in particular, causing dental protrusion involving the affected teeth. Sometimes, a slightly mongoloid facial deformity can be used to describe some thalassemic patients. This, on the other hand, is characterized as prominent frontal and parietal bones, a collapsed nasal bridge, depression of the zygomaticus, and upward slanted eyes. Investigations-wise, there are a few baseline tests that can be done for all new thalassemia patients. This includes full blood count, where in typical cases, the hemoglobin values would be less than 7 grams per deciliter, a peripheral blood film where you will see anisopoikilocytosis, hypochromia, microcytosis, basophilic stippling, Pappenheimer bodies, and target cells. You may also get a hemoglobin electrophoresis done, and in beta thalassemia major, a HbA would be decreased or absent, HbF is increased, while HbA2 would be variable. Remember that all nuclear family members must be investigated for hemoglobin electrophoresis for genetic counseling. First and second degree relatives should especially be encouraged to get screened and counseled, and this is known as cascade screening. Among the other tests that you could do would include a serum ferritin, red cell phenotyping, which is ideally done before the patient's first transfusion, liver function tests, infective screening, specifically HIV, hepatitis B and C, as well as VDRL, and once again, before the patient's first transfusion. DNA analysis is an optional test ordered, which is usually indicated as a confirmatory test in difficult cases, prenatal diagnosis, or for carrier detection. You may also want to do HLA typing for all patients with unaffected siblings. In terms of investigations, there are also some other tests that you may need to order to look at the severity and other associated findings related to the patient. Those who require a blood transfusion should get the Hep B surface antigen and Hep C viral antibody and anti-HIV antibody screening done every 6 months. During each admission for blood transfusion, one needs to calculate the volume of pure red blood cells transfused on the hematocrit of the pure red blood cells given, as well as the annual volume of pure red blood cells transfused per kilogram body weight. It is important to carry out liver iron assessment, where you could order a liver T2 MRI for non-invasive liver assessment of the iron content, and even carry out a liver biopsy for liver iron concentration and the assessment of hepatitis, fibrosis, or cirrhosis in selected cases, as well as prior to bone marrow transplantation. In addition to that, you will need to test for any diabetes by measuring fasting plasma glucose or perform an oral glucose tolerance test, hypothyroidism by measuring the free T4 and TSH levels, delayed puberty by checking Tanner staging every 6 months, measuring the LH and FSH, estradiol or testosterone levels, performing pelvic ultrasound for girls, and GnRH stimulation tests if appropriate. To check for any osteoporosis or osteopenia, measure the serum calcium, phosphate, ALP, 25-hydroxyvitamin D, and serum zinc levels. You may also want to order an anterior, posterior, and lateral view of spinal radiograph or a DEXA scan. In cases where endocrinology involvement is there or suspected, don't forget to check for any hypoparathyroidism by measuring the serum calcium, phosphate, magnesium, and ALP levels, whereas the baseline cortisol at 8 to 9 a.m. and ACTH stimulation test for hypoadrenalism. In those taking desferrioxamine or deferiprone or deferrixirox, you need to monitor for any drug toxicity. This is done by auditory and ophthalmology checkups annually, a full blood count monitoring weekly, ALT can be done 3 monthly, as well as urine protein levels monthly. In patients more than 10 years old, you will also have to do a specific cardiac assessment, such as annual ECG or Holter monitoring for arrhythmias, annual cardiac echocardiography, cardiac T2 MRI, or done once or twice yearly. Moving on to the principles of management of thalassemia, in beta thalassemia minor, patients usually would not require any specific treatment. However, you would need to educate and inform the patients that their condition is hereditary and that physicians could sometimes mistake this disorder for iron deficiency. Some pregnant patients with beta thalassemia trait may develop concurrent iron deficiency and severe anemia. Those with thalassemia major would need long-term transfusion therapy planned out, erythrocyte maturation agents, iron chelation, splenectomy, and allogenic hematopoietic transplantation later. Supportive measures, on the other hand, include folic acid replacement and monitoring for the development of any complications such as osteoporosis, bone fractures, poor dentition, pulmonary hypertension, heart failure, and aplastic crisis with parvovirus B19 infection. In alpha thalassemia, those with mild forms may not require specific treatment except as needed for management of low hemoglobin levels. Therefore, some patients may benefit from iron or folic acid supplementation. Those with more severe anemia may need lifelong transfusion therapy, while in very severe cases, allogenic hematopoietic stem cell transplant may be considered. Medically, you can manage thalassemia, especially those in severe forms, by long-term transfusion. The main goal of hypertransfusional support is to maintain the patient's hemoglobin level at 9 to 10 grams per deciliter, which can improve their well-being while simultaneously suppressing enhanced erythropoiesis. However, those receiving long-term transfusion also require iron chelation, as each unit of transfused red blood cells contain approximately 200 milligrams of elemental iron. Additionally, anemia and ineffective erythropoiesis downregulates hepcidin synthesis. Therefore, you require iron chelation to prevent the complications of iron overload, such as cardiac and hepatic dysfunction. Some examples of iron chelating agents includes IV deferoxamine, oral deferriprone, which are indicated in adults and children aged 3 years and older with iron overload due to transfusion for thalassemia syndromes, sickle cell disease, or other anemias. Surgical care would not be required in cases involving silent carriers or in those with alpha thalassemia traits. However, splenectomy may be beneficial for some patients with HPH disease. Splenectomy is often done to decrease transfusion requirements in patients with thalassemia major, as well as to prevent any iron overload and extramedullary hematopoiesis. It is rarely indicated in patients with thalassemia minor. The surgical procedure is usually done in patients older than 6 to 7 years of age, as post-splenectomy sepsis is possible. The patients should be vaccinated against encapsulated bacteria such as pneumococcus species, meningococcus species, and Haemophilus influenza. Usually, you would need to administer prophylactic antibiotics in children after splenectomy. And do take note that post-splenectomy thrombocytosis may increase the risk of thrombotic events, and thus the risk to benefit ratio for this procedure should always be cautiously evaluated before any decisions are made. There are some complications associated with beta thalassemia, such as anemia, extramedullary hematopoiesis, and asplenia secondary to splenectomy. And there are also medical complications from long-term transfusional therapy that can be considered. This includes iron overload, as discussed earlier, and transfusion-associated infections such as hepatitis. Interestingly, it was found that iron overload cardiomyopathy accounts for the majority of deaths in thalassemia patients. The risk of infections with encapsulated organisms like pneumococcus is usually increased, and this is due to asplenia or from iron overload in the case of infections with Yersinia species. Lastly, there may be increased incidences of cholelithiasis like bilirubin stones. Prognosis-wise, individuals with beta thalassemia, specifically thalassemia minor, would usually have mild asymptomatic microcytic anemia. However, this state does not result in mortality or significant morbidity. In the case of thalassemia major, the prognosis is highly dependent on the patient's adherence to long-term treatment programs, which would be hypertransfusional program and lifelong iron chelation. Allogenic bone marrow transplantation may be a curative approach. For silent carriers and individuals with alpha thalassemia trait, the prognosis is excellent. Looking at those with HPH disease, the overall survival rate varies, but it's generally good, with most patients surviving into adulthood. However, some patients have more complicated course and may not do as well. And lastly, patients with hydrops fetalis are incompatible with life and require identification in utero and in utero transfusions if the fetus is to survive and be born. Now let's summarize what we have learned so far. Beta thalassemia syndromes are a group of hereditary conditions which are characterized by a genetic genetic deficiency in the synthesis of beta-globin chains, while alpha thalassemia is characterized by reduced or absent production of one or more of the globin chains of which human hemoglobin is composed of. Normally, majority of adult hemoglobin is composed of 4 protein chains, 2 alpha and 2 beta globin arranged into a heterotetramer. In thalassemia, patients have defects in either the alpha or the beta globin chain, causing the production of abnormal red blood cells. The history and physical findings in patients with alpha thalassemia vary according to the number of alpha globin chains deleted. Additional beta chains and other hemoglobin abnormalities may also contribute to the clinical presentation. Lab evaluation, hemoglobin electrophoresis, and genetic testing are crucial in the diagnosis and the management of thalassemia. The therapeutic approach to beta thalassemia varies between thalassemia minor and major. Individuals with mild forms of alpha thalassemia may not require specific treatment except as needed for the management of low hemoglobin levels or anemia. We have come to the end of this topic. Thank you.